Hey, Ramesh, can you hear us?
Yes, I can hear you. Yeah,
Perfect. Thank you. Welcome.
thank you. Good afternoon. Can you hear me? Good.
You ready, Manny? Ramesh, we are. Amani has some troubles with the audio, no, with the mic, but I think that we can start, no?
Yeah, sure, sure. No problem.
Okay. Well, thank you very much for all the audience that are joining us today. For us, it's a great, great honor and pleasure to have Dr. Ramesh Kakunaya, one of the big stars in the infantile cataract surgery. It's a pleasure for us to having you in Kekesh, Ramesh. I know you are an excellent, a great professional in the field of the pediatric ophthalmology. I'm a fan of you, my friend. And we are pleasure and honored to have you here. I know that you are busy today. We have later the other meeting. And so I don't want to keep longer with this. This is your home. Kekesh is your home. Welcome and go ahead, my friend.
Okay. Thank you so much for the KKH group of hospitals and your hearty invitation for this talk. I'm going to share. I think I'll try to share my. Okay. The host has to. Okay. I can share it now.
Manny, can you there you go. Thank you.
Yeah, I'm fine. So I just wanted to know, can you see the slides?
Yes, perfect.
Uh, I think I'm audible as well.
Yeah, you can try to push the arrow to see if it's moving or not. I think you can.
Yeah. So let's start. I've just chosen a topic, pediatric cataract, the must knows for all, because many times the concentration is around surgery. I'm sure going to show some surgeries as well. But in addition to that, I'm going to share some holistic approach to pediatric cataract. I don't know, we're going to have question and answer at the end, or it's in between. I'm
No,
okay.
I think that you can. I think you can do your lecture, and at the end we can answer the questions.
Sure. So I'll go ahead. Again, welcome everyone who are tuned into this program. I'm happy to share some of the tips for pediatric cataract management. The objectives goes like this. The first one is workup of a pediatric cataract case. What all we must do in terms of workup. Second is the surgical consideration. And the third one is what are the post-op care, including rehabilitation, because this include the holistic approach. And the last bit, I'm going to cover a little bit of recent advances, what we have done in terms of making pediatric cataract surgery easier. So, as you all know, the big chunk of the childhood cataract causes the blindness around the world. It can vary from 6 to 22%. In some of the countries, it can be as less as 6%. And in some of the developing countries or developed countries, it can be up to 22%. It's almost 1/4. It can be familial like this, what you're seeing here. But one thing, whoever does pediatric cataract surgery must understand, we are looking at this. Can you see the globe size here? When the child is born or a newborn, it grows like this, both the curvature of the cornea as well as axial length. And in adults, the cataract surgery is completely different. Infantile cataract is different. Toddler or juvenile cataract is different. And little bit older children, the cataract is different. Because of this dynamic, what you can see here, there is a big dynamic change happening in infants. So how different? All of you know that we must always rule out ocular or systemic association more often in kids. It's almost always done under general anesthesia. So the anesthesia aspect as well as systemic health aspect is very, very essential. Suturing is a must in all cases of infantile and toddler cataract surgery. And as all of you know, where we avoid vitrectomy in adults, we don't want to do it. Here, 100% of the kids, we need to do it. And as ophthalmologist, always we strive to implant the lens in the bag if everything is suitable. And because of the dynamic nature of the eyeball, the IOL calculation and the power, and the final value what you get is a bit unpredictable. And we need to look into long-term follow-up. It's just a surgery is just a beginning of pediatric cataract surgery. How different it is? This part, the lens aspiration is kind of easiest. The next part is the primary posterior capsular axis. This should be around 1 to 1.5 millimeters smaller than the anterior capsular axis. We need to do a thorough vitrectomy, and the leading haptic must go inside the bag. And then the trailing haptic, as you can see here, it can be just nudged in. Once you have done, you have to clean everything. Sometimes you can see that this blood RBCs can go here. And as I said before, the suturing is a must in all the pediatric cataract surgery. Even this paracentesis incision has to be closed. If you look at the morphology, I must say that each child is different. Different in terms of response to your surgery, different in terms of the systemic association, different in terms of morphology. As you can see in this collage of photograph, there are so many things the face can tell you. what the patient has. Like if you see here, this patient has microspherophakia with the lens coming into the anterior chamber. This patient has a total cataract here. He has a high myopia in this eye. If you compare, this eye looks little bit prominent compared to this eye. This eye is becoming, because of hypotony, because of retinal detachment, he developed a complicated cataract in this eye. This is a child with post-radiation for retinoblastoma who developed cataract. This is microphthalmos with uveal coloboma and cataract. This is a typical rubella cataract, and this is a unilateral cataract here. So we have a different range, and the approach to each of these patients are different. In addition, we all have seen different kind of morphology, sutural, posterior subcapsular, total to anterior lenticonus. Can you see here? And the posterior lenticonus. They all can have different pathology and the different visual outcomes in terms of surgery. Why am I showing this? This is very important. And as parents, as teachers, as health workers, as pediatricians, many people have a bigger role in identifying, that is CAP, knowledge, attitude, and practice of pediatric ophthalmology or pediatrics. That way, you can see this top three: late presentations, failure to detect, and referral can be improved. That's why one of the publication, even in 2020, there are a lot of delay in presentation happening in some parts of the world. If you delay the cataract surgery, this is one issue everybody should understand. We are not looking for 20/20 vision in this girl. Because of delay in surgery, we did the surgery. She's still not able to really identify what it is on the day one. Because the cataract improves the vision as well. It improves the brain. Overall behavior of the child really improves. Look at this boy. He's trying to see something, but he does not know what it is. Look at this girl. She's trying to pick up something, but she doesn't know what it is. So all in all, the pediatric cataract surgery impacts vision and also impacts the brain in terms of behavior. Look at this infantile cataract surgery which has been done, and he's trying to do and trying to see at 1 year of age. He looks almost like a normal kid without any abnormality. He had an IOL in place. He is wearing the glasses for near as well as the residual hyperopia. His vision looks normal. This is what we need to strive in all these patients. In terms of etiology, there are different etiology. As you look at it, I would say 30% are hereditary, 30% are related to rubella in this part of the world, and almost 30 to 50% are undetermined. This is one of the theses done by one of our residents, Vivek. You can see in India especially, it's 30% familial and 35%. Even in 2020, there are typical rubella syndrome happening with regards to pediatric cataract. And if you see these three children, they have a similar dysmorphism. They directly say that all of them have rubella syndrome. And they can have a dirty cataract like this. It can be unilateral or bilateral. They can have pigmentary retinopathy, but with good surgery and rehabilitation, they can also do very well. I just wanted to share this picture here. This is the patient who had referred to as idiopathic cataract, but if you can see here, the diameter is, overall diameter is 8.5. Pupillary rough is not so healthy. There is meiosis, there is microphakia. Overall diameter of the lens is 5.5. And the child has this facies, and the mother has this kind of dot-like opacity. So whenever there is mother or maternal aunt or anybody has this kind of opacity, meiotic pupil, microphakia, hypotonia, typical diagnosis of Loeys syndrome. This way, last week, I think we had a WSPO's webinar. This stresses the importance what they said, the examination of the family members. This one finding led to the diagnosis of Loeys syndrome. So it's very, very important in terms of, and by looking at the face, you can diagnose many things. So whenever patient starts walking to your clinic, look into the face, look at the other systemic association, the way the child behaves, you can get a lot of information. This is the previous one is Hallermann-Streiff-Francois syndrome, very typical membranous cataract you can see. This is spondylometaplasia dysplasia with posterior subcapsular kind of cataract. And also try to use the investigations properly. This is the immersion B scan. You can see protrusion of the posterior capsule. This is a weak capsule seen typically in posterior lenticonus. You can also use this Schumfleg image where you can see the breach in the posterior capsule, and even the lens matter is going up to the vitreous cavity. So try to utilize whatever you have. You can see the cataract here, typical one. And also sometimes this helps you to really plan how you can do surgery. How can you plan the rhexis in this patient? All that, it really helps. So modern imaging systems like oculizer, you can really use in some of the older children to your advantage, both to understand what is happening as well as to plan your surgery. This is one of the paper by Dr. Coker. You can see in microspherophakia how beautifully this is seen. And also this can be really used as additional thing. Anterior segment OCT also can be used in terms of planning your surgery, especially in traumatic cataracts. And obviously UVM, especially in unilateral cataract like this, sectoral cataract, you can see this uveal mass here, which is causing this sectoral cataract in this kind of, in this child particularly. So, and also some of the cases of PHPV, you can see this red blood vessels. You can even use this carotid Doppler if you want to have a diagnosis. In addition, whenever you see a patient, this is the lens of the same patient. The anterior lens capsule is ruptured on both sides. It's not very clear probably to all of you. This part is ruptured here and this part is ruptured. There is no history of trauma. One can easily say that this is a ruptured pediatric cataract or a traumatic cataract and do surgery. But whenever there is a rupture which is spontaneous, this is the initial part. There is an anterior lenticonus where there is a prominent capsule, there is a stretching. Over a period of time, the anterior capsule degenerates and it ruptures. Think of Alport syndrome. So why am I showing this is just don't do cataract surgery. You could really do simple examination of the child in general. Look at the face, look at the morphology, look at the parents or the siblings. You can diagnose many things, as in this case, typical Stickler syndrome, where you can see hyperextensibility of the joint, vitreoretinal degeneration, etc., etc. Very, very typical phases of a Stickler syndrome with total cataract on both sides. These are all obvious cutaneous lesions. As you know, the anterior lens capsule and the skin, they are ectodermal in origin. They can also come with this kind of. You may not remember all this syndrome, but all of us should be able to pick up, okay, there is something abnormal in this. Let me help this child by looking at the literature, or even you can send them to a pediatrician or a geneticist who can really help us. So in short, I would say this is a good flowchart for diagnosis of congenital cataract. Examine family affected relative. If required, if there is a positive history, send to genetics. There is dysmorphism, sent to genetic or chromosome analysis, depending upon what you are suspecting. You can't just throw all the diagnosis for that child. Look at what exactly the child has. These are the two important things I do in all pediatric cataract patient, because these are the two cheapest investigation you can do. In your clinic, examine the siblings, examine the parents, look at the face, look at for any other systemic association. These are the first two steps. And obviously, we all ask history of pregnancy, birth, mode of delivery, etc., etc. We can pick up some of the cases of torch infections. You can see once the child is born, child may be failure to thrive, there could be systemic abnormality, there could be hepatomegaly, simple things. You can go in that direction of metabolic assessment. Sometimes pediatric cataract at birth, you may not diagnose something, but even during the follow-up, keep asking one question: how well the child is systemically. Not only look at the refractive error or a visual axis opacity or anything like that, but also look at how the child is doing in general. And sometimes you can have sporadic or developmental, especially in unilateral cataract. And you can also look at ocular associations like this. Typically, PHPV or persistent fetal vasculature, posterior lenticonus, traumatic cataract does not have any kind of systemic associations usually. And these tables are available in most of the textbooks, which are talking about typical morphology and their workup. But I must say that everybody should remember this way of working of every patient. That's extremely important. This is the favorite quote I like in one of Dr. Alex Levin's paper. Rather than searching for these diseases in those who have cataract, even more important is to screen those children for cataract who are already known to have these diseases. For example, child with Loeys syndrome diagnosed by a pediatrician. It's very important that we go and check them for cataract, or a juvenile rheumatoid arthritis. These patients we need to really check for these things. Then this is in short, I would say. Is it audible or is there any disturbance?
No, it's okay. We can hear you.
Okay, perfect. So examination of family members, look for signs of rubella and torch, specifically in all the developing countries, it's important. Cataract morphology as well as disc morphology, directed investigation is very important. If you can take care of this, I think most of the patients will go with the diagnosis or the association of pediatric cataract that child has. As I told you already, these are the 3 or 4 conditions where systemic association, you don't have to worry too much. In terms of preoperative checkup, we need to do examination under anesthesia. In rubella particularly, 20% of the kids can have an LDO. Otherwise, the chances of nasolacrimal duct obstruction in a child is 5%. Still, it's significant. Sometimes if you can't do it in the clinic, it's worthwhile to check here. Always check corneal diameter. All cases, gonioscope is a must. Intraocular pressure and pachymetry is very important, because this way you will have a baseline number. You can follow them up. IOL calculation under anesthesia is very important. You have to do keratometry, portable keratometer you can use, and also you can use a portable A-scan machine. Always wet the cornea. I don't want the cornea to be dry and parchment-like when you are doing this. Probably you can do this first and then go for the other things, because when you check IOP and other things, when you put a stain, there could be thickness can vary and you can have difficulty. You have 1 hour opportunity during anesthesia to check for what is the morphology. If you think there is something different, you can get additional investigations like ultrasound biomicroscopy and things like that. You will get. So This is a must. It takes a lot of time, maybe 20 to 25 minutes, sometimes 30 to 35 minutes, but it's worthwhile in all these patients. Once you have the IOL calculation, then we will go into the surgery. I just have few slides about intraocular lens calculation. This is, I've already alluded to, there is a significant change in the first few months, first year especially, in terms of axial length change. And there is a steep decline in the curvature of the cornea in the first 6 months. This is in the first 1 year, but this is in the first 6 months. So in the first 18 months, there is a lot of change happening in terms of axial length. What I generally use is this formula. For 1 year, 6 diopters of undercorrection. This is simple to remember. 1 plus 6 is 7, 2 plus 5 is 7, 3 plus 4 is 7. But what if the child is 1 year old, or maybe less than that, maybe 2 months old, maybe 4 months old, maybe 6 months old? 2 months old, if I select that patient for implantation, excluding all the exclusion criteria, I undercorrect up till 9 diopters. If they reach beyond 6, I might go up till 8 diopters. But if they cross 1 year, I might undercorrect 6 to 7 diopters. So 9 to 10 diopters when the child is around 2 or 2.5 months of age. That's the earliest stage I implant lens in these children. There are various publications on this intraocular lens power calculation and its prediction error. We found that SRKT and SRK2 was the most predictable in our formula. There are no consensus as such, but one has to look at your own follow-up of this patient and then come to a conclusion what works best. None of them are really 100% predictable. There is going to be unpredictability, but we need to adjust depending upon the child-to-child basis, or history of CVI, or the family history of high myopia. Other eye has high myopia. These are all variable things we need to think in terms of surgery. Let's look at some of the surgical aspect. The first one is in infants, whether IOL or aphakia. Both are valid, but you need to decide. This is my decision factor. Mithila is one of my fellow. When she was a fellow, we published this long-term outcomes of primary intraocular lens in infants younger than 6 months. What are the deciding factors? For me, there are 3-4 things which is the decision-making scenario for me. First one is the ocular, the eye per se. I don't treat as per age. I treat as per the patient as well as the eye of the patient. That's the criteria for me to implant or not. Patient is the criteria. It's not the age which is the criteria. When I say patient, what are the factors? Horizontal and vertical, wide to wide diameter more than 10 or 10.5, axial and more than 16.5. There are no associated ocular comorbidities like glaucoma, microphthalmos, ocular inflammation, anterior segment dysgenesis, Peters anomaly, things like that. If I find any intraoperative complications like a PHPV patient where the bag is really small, there is no space, the corneal diameter is really small, there is a hyphema, there is some bleeding from the angle, things like that, I defer IOL. And I also put this factor. All of us must remember, if you are surgically good enough, skilled, you can implant these lenses. But if you are not, if these criteria are not allowing you to implant, probably that patient is not fit for implantation in that particular case. Defer IOL in this kind of situation. Otherwise, in bilateral cataracts, I think it's a good idea to implant these lenses. In terms of practicalities of IOL implantation, I keep my anterior capsular axis around 5.5. The posterior capsular axis is just 1 millimeter less than that. Always try to use, if the economy of your situation does not prohibit, use cohesive viscoelastic. It's very good. Leading haptic should go in the bag at 6 o'clock or wherever you're going. Careful about inserting IOL behind the PCC. If you make a primary posterior capsular rhexis, if you implant directly, it can go behind. And if you have difficulty at the beginning stage of your career, implant in the bag and then perform some of the posterior capsular rhexis, which I will show some of the videos. I just wanted to share this video. This is a typical, I thought it's a typical developmental cataract or so, but it's like a petal, 3 petals are there here. But during surgery, carefully I looked at, there is some pearl like this. This is one of the surgery I was performing when I was in Orbis, when I was the Orbis volunteer faculty. You can see we are trying to do the capsular rhexis. What I do is I don't stain all the capsule. You can see this shiny material here. So if you tilt the globe, you can see this shiny capsule. Make a small nick there. This is a small nick using a cystitome there. Once you make, use this. This is a microcapsular rhexis forceps I use. Grab and regrab, grasp and regrasp. Make an initial. The size of the capsular rhexis should be the size of the nucleus, what you're seeing. That's what you need to aim. And if you can have a caliper of 5.5, that is great, but all of us don't have that. So in the beginning, I think all of us start with the lamellar cataract like this. So you can see the capsule, you can see throughout. Grasp and regrasp, grasp and regrasp as many times as possible. And then complete your rhexis. This is where the last part of the rhexis is happening. I'll just forward the video. What peculiar thing I saw in this case is, you can see these kind of pearls came into this port. Can you see this pearl here? I'm trying to aspirate from periphery, that is from the cortical matter to the coming to the central nucleus later. Trying to aspirate. As I'm aspirating, these things, sometimes it's unpredictable that these materials can come. It is so calcified, they're all dispersed. See this? This is what I had to do is I could not complete the aspiration. I had to pick this like a pearl picking. I had to pick each one of them because they were coming to the port and clear everything. And then I could complete the surgery. So be prepared for whatever. Sometimes this can be calcific. We might have to use a phaco. That happens in 5 or 10% of the cases. You have to use it. So you can see that at the end of the surgery, in this particular case, I can still see a tag of capsule here. You can just trim it using the same capsule. So you have a capsular rhexis. The next thing what you're going to do is the primary posterior capsular rhexis. Inject viscoelastic. Don't overfill the anterior chamber. Just fill the anterior chamber. Don't fill the back. Just begin with this capsular rhexis. Personally, I feel posterior capsular rhexis is a bit easier provided you cast this properly. Sometimes it becomes smaller when you're doing it as you are going. It's a very elastic tissue compared to anterior capsular rhexis. It's very, very elastic compared to anterior capsular rhexis. So whatever, how many hour time you grasp and re-grasp, that just tries to go out, it's going out of this place. And try not to catch. If it is too difficult, implant the lens. I was saying the leading haptic directly goes into the, you can really push it because you are pushing into the bag there, not downward. This is very important. Now, what I am seeing is the trailing haptic should go inside, but see this, the posterior capsular rhexis is not enough in this patient. What you have to do is you need to enlarge. How do you do it? This is where I wanted to show this video. You can aspirate everything. and then just gently lift the lens here and go behind, and then try to do the capsulorhexis. So there is some kind of tilt from the IOL here, but you are able to do the capsulorhexis. Keep your vitrectomy very high, maybe 2000 or 3000, whatever your machine allows, and shave it. You have to rotate your the probe very nicely, and then now you have a larger capsulorhexis here. One of the things I stress upon is the polishing of under surface of the anterior capsule up till the equator, because this is important in preventing, not 100%, at least to some extent, the lens epithelial cell proliferation. This is extremely important. That's the end of surgery. And after that, you need to do a suturing. All wounds we need to suture. And then intracamerally, I give moxifloxacin, and subconjunctivally, I give the dexamethasone after the surgery. This is another patient I just wanted to share here. This is the posterior lenticonus. You can see here. We are performing the capsulorhexis in this stage. So this is the lenticonus part, this part. So there are two important things to be taken care in posterior lenticonus. Aspirate from the periphery first. Come to the center where there could be a defect, and don't do capsulorhexis, the hydrodissection procedure here, and aspirate as much as possible and come to the center at the end. You can see now there is an opening here. In this case, I know that opening is very visible. What I am trying to do is implant in the bag. Again, be very careful because the posterior, always there is an opening there. Once you have this bag, gently nudge into it. The trailing haptic has to be nudged in, and it easily goes. You don't have to put posterior pressure here, and it covers, and then go behind this and then complete your rhexis there. Posterior lenticonus can be total cataract as well, as you are seeing here. This is the edge, possible edge of the defect of the posterior capsule. I stain in this kind of situation where there is a total cataract, trying to aspirate everything from center to periphery. But at this stage, I could see that vitreous is already there because it's a big opening there. But it's an elliptical opening. I know that 12 o'clock and 6 o'clock, there is enough space for me to implant the lens. Inflate the bag very nicely, if possible, with the cohesive viscoelastic. Once you have done that, this is where you need to decide whether you are able to implant in the bag or in the sulcus. If you are unsure, open a 3-piece lens than a single piece. Here we are planning to implant in the bag. Keep this as 12 o'clock and 6 o'clock position. As I said before, inject directly, and then this is in the bag, and just nudge the trailing haptic, and then always suture the wound once you have done everything. Sometimes you can get some kind of membranous cataract. You can see here, as I am trying to do, this is just a membrane. You have 2 to 3 options in this case whenever there is a membranous cataract. What I do is I do a plaque rhexis, gently peel off this cataract, but don't forcefully pull it, because if you pull like that, whole back can come. So be very careful. If it is not coming, use a scissor. It's coming almost everywhere, except this part is still not there. Again, grasp and regrasp. You can also cut with the vitrector, but it may not be precise. But if you can debulk the lens by doing a plaque rhexis, it's always always helpful. If the last part is not coming, you can use this small rhexis forceps to cut it and then pull off this lens, the lens matter. And then you can go ahead with the implantation and primary posterior capsular rhexis, etc. So this makes things easier. That's why small little bit instruments can really be very, very handy. I just wanted to show a post-retinal detachment patient. We had a complication here. You can watch this video. There is a learning point from this particular surgery here. That's the silicone bubble which was there in that position. We removed everything. We are going ahead with the capsulorhexis. Once we have done capsulorhexis, I'm trying to aspirate. Everything going on very, very smoothly. There is no complication at this point of time. You can also see that some of the bubbles are coming along this port. Once we have done, excuse me, you can see the last part of the lens matter has been aspirated. You can change your hand. It's best to be ambidextrous. You can change from this side and you can change from that side and you can aspirate. Still some more bubbles are coming. I went back and then trying to aspirate the last part. Some iris is coming, but you need to avoid that. Almost it's complete. And then I came out and tried to aspirate that. See what happens now. See, there is a sudden giveaway. The reason for that is the bottle height of the flow rate was still the same. We need to understand that post RD surgery, the vitreous is not there. Everything is soft. The anterior chamber can really become very deep. That's why we can easily avoid these kind of things. Okay, we will go ahead. If we have time at the end, we can come back to this. Some of the videos we can. One of the thing which can be a possible game changer in pediatric cataract is the Zepto pediatric cataract surgery. Zepto assisted or a precision pulse capsulotomy with the handpiece. You can use this. This is the handpiece. This goes inside. This is a silicone bag. This is the nitinol ring. It heats up when you give this laser. Once the heating up is over, suction and the reverse suction should be given. This just takes 30 to 40 seconds. Once it is done, we come out, pull it back, and you can see the rhexis there. This can really help whoever does not have good experience. It can be useful for the anterior capsular rhexis. This cannot be used for the posterior capsular rhexis. Still, we need to go ahead with the, see, in spite of that, you can see a round regular capsular rhexis. You need to capsule polish around. And then for the posterior capsular rhexis, you still have to use the manual one. You cannot use the precision pulse capsulotomy there because it cannot create the pressure there. So in view of that, we cannot really use. But for the anterior capsular rhexis, it can be used. But with the current probe, it really too big. Sometimes in infantile cataract, the estimated and the actual capsular rhexis can become a little bit bigger. That's why we need a smaller handpiece for pediatric cataract. That's the issue with the Zepto rhexis. Otherwise, it's a good thing. These are some of the images of the long-term patients, what we have. And this is one of the patients we have where even we implanted after the precision pulse capsulotomy. This is one of the lenses which is designed by Dr. Tazignon from Belgium. We have implanted in the bag. It's a long term. So this is the bag in the lens. This really helps in preventing the lens epithelial cell proliferation. This is one of the surgery of the bag in the lens where this was a total cataract. We used again Zepto in this case for the capsular rhexis. After doing Zepto, we aspirated everything. And one of the thing for the bag in the lens is anterior and the posterior capsule or axis size should be similar. It should be little less, but it should be almost similar. So that way we can see, this is the bag in the lens, what we really have. It can be folded and it can be folded onto your C or D cartridge, and it can be implanted there. It's pretty easy to implant into the AC and into the sulcus. But the real trick is afterwards to engage this haptic, round haptic you can see, between the two leaflets of the two capsules, anterior and posterior. Once it is done, rest of the things are pretty easy. And this is, you can see, there is a slight nasal decentration because we did a little bit nasal capsule. That's the only limiting factor of this lens, and this is the long-term outcome of this bag in the lens placed there. So these are the patients with these kind of designs. It's really good. In terms of medication, I use prednisolone acetate, hometropin in older children, atropine eye drops in younger children, and tobramycin or moxifloxacin eye drops, and also suture removal after 1 or 2 weeks. I use glasses, single vision for infants, and bifocals when they start walking. And these are some of the long-term things. Contact lenses are best actually, but care and maintenance and expense and infections are a part of it. And the follow-up is very important to take care of all these things. Some of the patients can even drop out after first year. This is one of the curves showing our follow-up rates after 1 year, it significantly drops. So we need to keep on calling them to come for the follow-up. I just want everybody to focus on this slide. That's the real follow-up. The mnemonic is real, R-E-A-L. R for refraction and visual acuity, E for eye pressure, A for alignment and ruling out amblyopia. If it is there, treat them. And L for lens-related parameter. This applies to all pediatric surgery, either cataract, cornea, or anything. We must do a real follow-up for a very, very, very long term. Then only we can give good vision for these children. As you can see, this patient has a significant microcornea. We could not implant a lens here. We could only give glasses. You can see with the glasses, he's doing pretty well. I just show this video, how he is playing and things like that. So either contact lens or even glasses or intraocular lens, depending upon that, if you take care of evaluation, surgery, and a good follow-up, all these children do very well in terms of a long-term outcome. And the EUA rate has really come down after this eye care tonometer. Most of the patients, you can check pressure in the OPD itself. And this is one of the patients with long-term follow-up. And for this child to appreciate the Harry Potter and read this story with 2 months aged cataract, it's really a long, long way. So in summary, I think pre-ops assessment, intraoperative assessment and decision making. Surgical aspect, I'm not put it in bold, but it is important. But the rest of the things which are in bold are very, very important in the long term for these kind of patients. Thank you very much for all your attention and listening to this talk. And I'm happy to take any questions. And I'm happy to learn from all of you if there are any comments. Thank you.
Thank you, Dr. Ramesh. I hope you hear my voice now.
Yes, I can.
Yes, so I'm very sorry for the inconvenience that happened in the beginning. I would like to thank you for accepting our invitation to Keikash Global Education Forum. So I'm just going to give a few words about Dr. Ramesh because he was not introduced properly in the beginning. He's the director of Child Sight Institute in Justi Ramanama Children Eye Care Center. He's a consultant of pediatric ophthalmology, strabismus, and neuro-ophthalmology at LV Prasad. He's Adjunct Clinical Professor at Castrupa Medical College, Manipal, Associate Professor at University of Rochester, New York, and at Case Western University, Cleveland, Ohio. He has more than 100 publications, and he's an executive committee member of World Society of Pediatric Ophthalmology Strabismus, which he has a meeting after an hour from now. So we're not going to take a long time. It was an excellent talk, nice videos. I'm going to just ask you the questions that came in the question column. So one question was, do you do posterior capsulotomy and vitrectomy after IOL implantation sometimes? I think from the videos you showed us, right?
Yeah, I do very, very rarely. I always do the primary posterior capsulotomy as well as vitrectomy first, and then I implant. But in cases of posterior lenticonus, in cases of inadequate posterior capsulorhexis, I do this procedure just by lifting the IOL, and I complete. Both ways I do it, but majority of the patients I do PPC and AV first and then implant the lens.
So for training of resident and fellows, which way do you prefer?
I know. This is an excellent question. I always keep telling my fellows and all the doctors who are in the beginning stage, implant the lens and then do a vitreorhexis, or not vitreorhexis, capsulorhexis and then vitrectomy. Because if you have implanted the lens in the bag, most part of your tension is relieved. But once you get some experience, then try to do this. So I completely agree with you. It has to be implantation in the bag and then perform this. Once you are skillful in that, then transit into this things. Okay. But having said that, at some patients of posterior lenticonus, you will be thrown into that kind of situation. If you are not able to implant in the bag, implant in the sulcus, but open a 3-piece lens.
Okay, so one nice question is, any precautions or comment for capsulorhexis in anterior polar cataracts?
I had a case, but I didn't have time to show. Whenever there is an anterior polar cataract, there could be a kind of adhesion between the cortex, not with the cornea, with the cortex.
Yes.
It cannot be. Your capsulorhexis can be routine, but by pulling the last thing, you have to be careful. Because if you pull completely, it might be adhering to the cortex, so you might have to use scissor. But if there is an anterior plaque kind of thing, then you'll have to use scissors all around. But for anterior polar, I will do similar, except that last part, I will pull it very, very carefully. These are the only tips.
Do you do optic capture and posterior capsulotomy? Do you do the optic capture?
Yeah, we had a discussion last week, I think. I generally don't do it, except in cases of traumatic cataract, where there is not much of a support to keep the lens in the sulcus or in the bag. I do posterior capture. Otherwise, generally, I am a proponent of in the bag implantation and very good vitrectomy and posterior capsulorhexis. Except in these situations where there is not much of a support to keep the lens there. I feel if the lens in the future must be floating around, I want it to be fixed somewhere in the posterior capsule. These two situations I do.
So what is the youngest age you do a vitrectomy in traumatic cataract?
What is the youngest age, is it?
Youngest age you do vitrectomy, anterior vitrectomy in traumatic cataract.
I do it in all patients with traumatic cataract, except in older patients, maybe more than 8 or 9, where there is no plaque, it's clean, the posterior capsule is really clean, I don't do it. Otherwise, I try to do it. People say that there is a chance of infection. Yes, there is a chance, but we need to rule out all the intraocular foreign body and everything before doing this cataract surgery. And I always check the fundus before closing in this traumatic cataract. So it's very, very important There could be retinal detachment, there could be a foreign body, there could be a mud inside. All this is possible. But I do vitrectomy. I also inject always intracameral antibiotic.
Okay. Someone is asking about how many sutures you put at the wound, 1 or 2. And what do you think about the sutures?
Yes, all infants and toddlers, I do put 3 sutures, one each for the paracentesis, one for the main. After
Okay.
4 years or 3 years, I put maybe only one, and after 4 years, I may not even put a suture if I feel the wound is quite stable. Otherwise, I am a proponent of putting multiple sutures, in the sense 3 must in infantile or toddler cataract. If I put
Okay.
an IOL, if I don't put an IOL, just 2 sutures for the paracentesis. That's it.
Okay. What are the measures you use to control bleeding in persistent fetal vasculature?
I take care of 2 things. One is I don't cut if I see an obvious vessel in a membranous type of persistent posterior fetal vasculature cataract. That's number 1. And if I find a vessel either in the posterior part of the cataract or in the anterior lens surface, wherever it is, I use an endocautery, what is used by the retinal surgeons. You can
Okay.
enter through the paracentesis. I cauterize that and then perform the vitrectomy. That really prevents bleeding. That's the intracameral cautery I use always in PHPV cataract or persistent fetal vasculature cataracts.
Okay. So Dr. Matar, one of our colleagues that was in Kekish, is asking you, do you do bilateral cataract surgery in one setting or you keep them on 2 different days?
Very, very rarely I do simultaneously, because if the patient has a very, very high risk of anesthesia, maybe severe cardiac issues, then I do. Use 2 different sets of instruments, chain the gloves, everything. Very, very rarely I do. I do maybe 2 or 3 in a year, not even more than that. I am not a proponent of bilateral simultaneous cataract surgery.
Okay. So how important is hydrodissection in pediatric cataract?
For me, it does not make any difference. Really does not make any difference. What makes a difference is the lens capsule and the equator polishing after lens aspiration. I spend a lot of time on aspirating these small cells than doing a lens aspiration. There is a paper, hydrodissection reduces your surgery by 20 seconds. So probably that's what it is. I don't think it makes a big difference. And you need to be very, very careful when you are dealing with the total cataract, because you might be having a posterior lenticonus there. You might be dropping all the material into it if you do a posterior capsule, the hydrodissection. I avoid it in all the patients. I don't think it's very important.
Okay. So in many cases of posterior lentoglobus, the intact part of the posterior capsule is very thin. How safe do you think putting an IOL in the bag?
Yeah, this is a very, very interesting, and I've been asked about this question from the last 15 years, and I am following up my own patients, because that's theoretically exactly a very valid question, because we always see that elliptical shape of the poster capsule is weak. In my opinion, it does not extend beyond that. So I have seen this follow up over a period of time. In spite of having that dehiscence, I am not worried that one day lens will go down. I feel it remains stable and it remains that elliptical throughout their life. So I am not worried that that will go inside. But if the opening is too big, probably it's best to implant in the sulcus and then do a optic capture probably.
Okay. There are many, many, many questions. I don't think we will be able to answer all of them.
Yeah, I can. I have to go in another 15
Yes, I know you
minutes
have
for
another meeting.
another webinar.
Yes.
I can answer if the time permits for the next 15 minutes. No issues.
You can answer, huh? So one of our colleagues is telling us he has a case of alpha monocytosis. It seems like a genetic disorder with dense bilateral cataract. He's 4 years old, and his axial length is 16 millimeter. His IOL calculation is 41 and 43.
Yeah.
So how would you manage this case? So let's talk about let's talk about bilateral cataract in those who have genetic disorder with systemic diseases usually. How do you approach these patients?
Yeah, I always take a very good evaluation in terms of systemic that affects the general anesthesia issues.
Yeah.
Once that is taken care, I treat them almost similar if they don't have any ocular association. For example, if a patient with Loeys syndrome, I know the capsule as well as the lens and the pupil, everything is really small. I would not implant a lens there. But in this case, the axial lens seems to be 16. And I'm sure the patient has some kind of posterior microphthalmos and things like that. At 4 years, if it is 16, I don't think so it's going to grow much, maybe 1 millimeter or so. So what I would probably do is I will look at what exactly, is it a microphthalmos, anterior microphthalmos or a posterior? If it is still posterior, I might be able to implant a lens in this patient. 40 is not available. I would like to look at the anterior chamber depth as well as lens thickness. I will make him at least, as much as less hyperopic than possible. I don't want him to wear a 40 diopter lens. But if it is a posterior microphthalmos, we can do it. But if it is anterior microphthalmos, probably I don't think so we have a choice of implanting a lens in this child. In all probability, I think patient will have anterior microphthalmos as well.
What is the minimum horizontal cornea diameter you implant an IOL in?
10 and 10. Minimum is 10 millimeter for me.
Okay. So one of our colleagues is asking you, what is your workup for microspherophakia cases?
Yeah, microspherophakia, again, I will look at the dysmorphism, whatever is there. I had actually a video and a case, but because of time factor, I could not show it. I would take an opinion from a pediatrician in terms of ruling out all the associations. And then obviously I will do a lens evaluation. I will do a gonioscope if the child is older. And then as all of us know, it causes a significant myopia. And one day the patient is going to have a glaucoma. I am in favor of removing the lens in most of the cases. I try to remove the lens in most of the cases. But if I feel the patient is ready for frequent follow-up and things like that, I observe them. But I don't think so there is any role of just doing a PI. It's not really going to prevent the glaucoma. In terms of other workup, I leave it to the pediatrician and the genetic group. We need to do a all array of tests, including systemic examination. Genetic is not possible for all our children because of financial issues, but whenever possible, we will get it done. But majority of our patients are not able to afford the final test for the genetic, because that's the thing which really differentiates whether they have any association and things like that. We can only rule out any obvious anomalies like, fingers, all that. But genetic tests, all the patients are not able to afford.
Yes, I know. So someone is asking what type of bimanual you're using, 21 gauge or 23? The
23
size?
gauge. 23.
Okay. And do you use sometimes dispersive viscoelastics, or you don't use them?
For me, not really. I don't use much of dispersive, because one is that they are expensive. We are allowed only some kind of thing. So I use most often cohesive type, specifically for the anterior capsular axis, because it has got a very good property of deepening the anterior chamber and dilating the pupil up to 10 to 20%. Just this viscoelastic can dilate. And it makes the anterior capsule really flat. So capsular axis becomes easier. But for the vitrectomy and other part, actually, it comes as a blob at the end. It
Yes.
just at one time.
Yes.
So
Yes.
it really makes your surgery a little bit messy. And if you leave it them there, it can cause glaucoma on the next day. So you have to be careful. I'm fond of cohesive viscoelastic only for the anticapsular axis. For the posterior capsular axis as well as vitrectomy, I don't use much of viscoelastic.
Okay. Any preferred IOL for capsular bag implantation versus sulcus implantation? Or an IOL? Yeah, okay, you can tell us. Okay.
Yeah, single piece lens for in the bag, and I prefer the 3-piece lens for the sulcus implantation. That's what I use. And I don't use hydrophilic lenses. We had not so good experience with the hydrophilic. So I always use hydrophobic lenses.
Okay. One of our colleagues is asking if you have a newborn with bilateral dense cataract, when do you do surgery?
Bilateral cataract around 6 weeks of age, 6 to 8 weeks. If we can push up till 8 weeks with all the things, you can even plan a possible intraocular lens in that patient because the diameter will be good. 6 to 8 weeks. I used to do really very early surgeries, maybe 2 weeks, 3 weeks, but
And then
really
you
they develop glaucoma. Chances are really very high. I push unilateral up till 5 weeks, 6 weeks. Bilateral maybe up till 6 to 8 weeks because each week makes a difference in the newborn. Really
Yes.
makes a difference.
Yes. So last two questions. What is the IOL you use in microspherophakia? Which IOL? Is there any certain?
I have a small series of patients which in selected microspherophakia, I use this. If the whole lens is out, then we use a sutured or a glued IOL. But if the lens, everything is stable, we even use single piece in the bag implantation. Again, I forgot, I did not have time to show this, but I would not recommend for all patient, but there is a role of in the bag implantation in selected patients. Otherwise, after 4 or 6 years of age, you can implant the glued IOL for these patients after doing a lensectomy.
Okay.
That's what I would.
Last question is about steroids. What steroid you use at the end of the surgery, and do you give systemic steroids to these patients or not?
Yeah. Systemic, I'll come to the systemic steroid only in cases of juvenile rheumatoid arthritis patients where I have implanted the lens. There is a significant inflammation. I put there. In the second scenario, that's the only scenario I will give systemic steroids. And with the steroid regimen, my regimen for the patient, infant or toddler, is subconjunctival dexamethasone after the surgery. That keeps the steroid for the first 24 hours. I'm happy. Even if the child is cranky, not putting the drops properly for the first day, I'm happy because already it's there. From first day onwards, I give steroids depending upon the inflammation and depending upon the etiology of the cataract, 6 to 12 times. It can be as less as 6 times. It can be as high as 10 to 12 times, along with atropine eye drops in children less than 1 year, home atropine eye drops in children older than 2 years. 2 years, right? I taper every week for the next 5 to 6 weeks. That's my steroid regimen.
Okay. So I thought we don't usually use dilating drops if we put IOL. So you do put it to avoid inflammation or synechia?
I put it for one is to avoid inflammation. Second is there could be synechia between the lens and third, this is my own interpretation. It causes less glaucoma, I think, if the pupil is really dilated. I don't have evidence. I don't have a paper to show. This is my own observation over a period of time.
And use it for how long and how many times per day? So we'll be using it.
Atropine, right? Atropine?
Atropine, we usually give it QHS. Do you give it more than QHS? Or what do you give?
Just
both.
For 2 weeks, that's it. And I always tell the parents to block the nasolacrimal duct whenever they put these drops. Atropine can cause facial flushing and fever. That's why they have to close it. And even steroid long-term use can cause adrenal suppression. So systemic absorption of even a tiny drop of steroid is not good for an infant. I always ask them to occlude the nasolacrimal duct and then.
So there are two physicians want to ask a question. Is there time for you, or you want to leave?
Yeah,
as
quickly I can go,
okay.
And then I have to run for the other one. Yeah.
Okay, so we'll Intisar, you can talk. We're hearing you. Hello? Okay.
On my mic.
Or what about, okay, Caroline? Do you hear us, Caroline? You're allowed to talk if you have a question. Okay.
All right.
Okay, it's okay. So I think by that we conclude. Thank you so much. It was a great pleasure having you. I'm sorry again for the inconvenience that happened in the beginning.
No, then thank you. All the time, sometimes we can expect these technical glitches. Thank you very much for all your help. I hope it was useful.
Thank you. And hopefully we'll meet again, inshallah. Thank you so much.
Thank you. Thank you so much for this. Thank you. Have a good day.
Bye-bye. You too.
Bye.